Thank you very much, everyone, for participating. My name is Steve Ansell. I'm from Mayo Clinic. I'm delighted to be joined by a number of my colleagues, all of whom are experts in Waldenstrom's, and we're going to look forward to their opinions and input on a few critical questions. So I'm just going to have them go around and introduce themselves. Dr. Castillo, maybe you can start and introduce yourself. That'd be great.
Yes, thanks, Steve. My name is Jorge Castillo, and I'm the clinical director of the Bing Center for Waldenstrom's Macroglobulinemia at the Dana-Farber Cancer Institute in Boston.
Excellent. Dr. Thomas.
Hi, I'm Sheeba Thomas. I'm on faculty at MD Anderson Cancer Center in Houston, Texas.
And Dr. Minnema. You're going to have to take yourself off mute, Monique.
Hello, my name is Monique Minnema. I work as a hematologist in a University Medical Center in Utrecht, the Netherlands.
And Dr. Buske.
Yeah, my name is Christian Buske. I'm medical director at the University Hospital in Ulm, southern Germany.
Really grateful for each of you being part of this, and three main questions we want to talk about today, each of which I think is really important in practice. And so the first we want to talk about is what really constitutes refractory disease. So many times we all kind of watch the numbers, we see people getting symptoms, we talk about them being generally in good health while they're on therapy. But as we're looking to new drugs and new therapies, I guess the key question is, what do you constitute, what in your mind constitutes a patient that has refractory disease? Maybe, Christian, you want to start us off?
Yeah, so normally, of course, we look at, let's say, disease manifestations. So, parameters which we can measure. So this is what we are used to. And of course, depending on, let's say, the disease manifestations of the patient before treatment, we are used and trained to look at, these disease manifestations upon treatment or after end of treatment. And I think this is for sure very important, but as I said, I think it's an important question how we deal with patients who have, let's say, stable disease with regard to measurable parameters, but have clinical benefit. So just to open the discussion a little bit, so even although we would not see any major improvement in these in these parameters which you can quantify, these patients, when they have a clinical benefit, to my mind, they are not really refractory. I just wanted to mention this to open the discussion.
No, I think that's a very valuable place to start. So I'd love to open it up to the rest. Other thoughts? I think there are kind of two contexts, if you like. It's the people who clearly had a benefit and now are losing potentially the benefit, or to the point never had a benefit, or clinically had some improvement, but not really parameters that we track on different. So love to hear from you kind of how you think about that. So the rest of you, any other comments?
Yeah, so I mean, I think what makes it a little bit more complicated is that we don't have an actual definition of refractory disease in Waldenstrom's, right?
Right.
And I guess we can think about a series of different potential scenarios in which we can talk about refractory disease, right? We have the patient in whom the numbers get better and the symptoms get better and very quickly, and we can still decide what quickly means, right? Could be on active therapy, could be, within 6 months of stopping such therapy or so. There is a disease relapse, and we can consider those patients to be refractory in the first place. We do have the patients, as we described before, who actually do have improvement in symptoms, but the numbers really didn't improve much. Are those really refractory, right? If they're having actually clinical benefits, even though they have not had an actual response based on IgM levels, they do have an improvement on the symptoms. Are those refractory, yes or no, right? And we will need to define that very carefully. And then we have the opposite, right? Patients who actually have the numbers look great and the symptoms are just not getting better, right? So are those patients refractory, or even though, by numbers, they're supposed to be doing better, right? So I think there's a number of potential clinical scenarios, and I think elaborating or formalizing a definition of refractory disease that we can use in clinical practice as well as clinical trials, I think it will be very helpful.
Yeah, thank you. Valuable. Sheeba or Monique?
Yeah, I can.
I think. Oh, go ahead.
Go ahead.
Oh no, certainly I second what's already been said. I think there are those patients, especially on fixed duration therapy, where we see a progressive shortening of the response duration and the time until new symptoms are recurring. So I would just add those folks in to our refractory definition.
Right. And Monique?
I really like the explanation that Jorge just gave, because it's quite complex. And what I do in my clinical practice is that before I start treatment, I decipher what is the goal that I want to achieve in these patients. Sometimes it's because patients are so tired, or it's because they have anemia. But sometimes patients do have a M protein related disease, so they can have amyloid or anti-MAG neuropathy or signs like that. And in those cases, the numbers are sometimes a bit more important than the clinical aspect that patients have. So in my view, a really patient-tailored experience setting must be applied in that setting. I must admit, for clinical trials, that's much more important, because then you need a broad definition, of course, what is refractory, and that's still lacking.
You know, I think you make an excellent point, and I think that's one that I try and do in my practice, and that is really define what do I believe is disease symptomatology, and obviously parameters that are purely related to Waldenstrom's, and what are other symptoms that may be either coexisting or parallel. Because to your point about what do you constitute a response, because you can have somebody, and I think, Jorge, you said this very well, parameters look great, profound fatigue that is no better, and hence you say, is that refractory disease? You turn out the person has severe sleep apnea or something, which is causing the fatigue, and it's actually divorced from the exact issue that you're trying to treat. So really defining what you believe is an improvement and what you're trying to achieve, I think is a very valuable thought. Anyone want to add to that a little more? Other thoughts?
Perhaps one quite not unique, but particularly in Waldenstrom, what we have to stress, you have to be also sometimes patient. So in the sense that don't define a patient too early as refractory, because we see also even after ending treatments improvement in certain parameters or even symptoms. I think that's quite typical for Waldenstrom. So it's also the question, of course, it's depending on the individual situation, but a little bit how to define refractoriness and to a refractory disease. And yeah, I think it's important that you also give the patient time to respond.